There is one change I make with my patients that reduces their risk of dying from a heart attack by 56%. No new prescription. No additional cost. No altered diet. No grueling exercise regimen. No supplement regimen stacked on top of what they already take. Same pill. Same dose. Same pharmacy. Different hour. Within 48 hours of that single shift, their body begins doing something it has not done in years, protecting itself during the most dangerous window of the day. A window that opens every morning whether they are ready for it or not. Your doctor has almost certainly never raised this with you. That is not negligence. It is not secrecy. It is something far more ordinary, and in some ways, more troubling. The instruction to take your blood pressure pill in the morning was standardized in 1955. The peer-reviewed evidence proving it should be taken at night was published in 2020. 65 years between the protocol and the proof. Your doctor is following a rule older than color television. Not because they are wrong, because no one updated the manual. I am going to show you exactly what time the change applies to. Which medications benefit from the switch. Which ones must never be moved, and the precise words to use with your physician so this conversation goes smoothly and safely. Here is what I need you to understand before we go further. Every single morning, your body opens a 6-hour window when your blood pressure is climbing toward its daily peak and your medication is quietly bottoming out. These two curves, pressure rising, drug fading, cross at the worst possible moment. Most people over 60 have been feeling that window for years. The heavy pressure behind the eyes at 5 a.m. The heart pounding before the feet hit the floor. The hour in the recliner waiting for the morning to become bearable. That is not aging. That is a timing problem. One important note before we continue. I am Dr. Alex Thompson. And while I am a physician, I am not your physician. Do not adjust your medication schedule without speaking directly to the doctor who prescribed it. Some pills carry real risks at night. I will identify each one clearly. This is information to bring to that conversation, not to replace it. Now let me show you the window. The number on your blood pressure cuff right now is not the same number it was 6 hours ago. It will not be the same number 6 hours from now. Your blood pressure is not a fixed measurement, it is a living wave, rising and falling across every hour of the day, following a biological rhythm as precise and predictable as a tide chart. You have felt this rhythm your entire life. You simply never had a name for it. That heavy, slow-moving feeling that settles over you around 2 in the afternoon, the one that makes the couch look unreasonably appealing. That is not laziness. That is your blood pressure dipping as your body quietly reroutes circulation toward digestion. The sluggishness is real. The biology behind it is measurable. The unexpected second wind that arrives around 4 or 5 in the evening. That sudden sense that you could actually accomplish something, that is your pressure climbing again. Your body's final push before it begins winding down for the night. And then there is the morning. If you have ever woken before sunrise with your heart already hammering, a dense pressure lodged at the base of your skull, a sensation that your body launched into full alert before you even opened your eyes. That moment is the most cardiovascular, dangerous point of your entire day. Between 4 and 10 in the morning, your body executes what can only be described as a controlled detonation. Cortisol and adrenaline surge into your bloodstream simultaneously. Your blood vessels constrict. Clotting factors activate, making your blood measurably thicker than it was at midnight. Your heart accelerates to meet the sudden demand. 40% of all heart attacks occur in this 6-hour window. 49% of all strokes. Sudden cardiac death peaks between 7 and 9 a.m. This is not misfortune. This is predictable, documented, recurring biology. 3 forces converge every single morning: vessels tightening, heart pushing harder, blood thickening, and they peak together at precisely the same hour. Every day, without exception. Your medication was prescribed to stand between you and that convergence. But here is the problem. If you swallowed your pill yesterday morning at 8, it peaked around noon, held through the afternoon, and began its slow decline by evening. By 4 a.m., it was nearly exhausted. By the time the storm arrived, your bloodstream held almost nothing to stop it. That gap has been opening every morning for years. A man named Arthur lived inside that gap for 6 years. And it quietly took from him the only thing that made retirement feel worth it. Arthur was 71 years old, a retired master carpenter from a small town outside Asheville, North Carolina. For 35 years, he had built furniture by hand: dining tables, rocking chairs, bookshelves designed to outlast the people who commissioned them. His hands were his instruments. He could run a fingertip across a joint and tell you, without looking, whether the fit was true. When he retired, his daughter said he would be impossible to live with, unless he found something to build. She was right. He converted his garage into a woodworking studio, hand planes hanging in rows, chisels organized by width, a workbench he had constructed himself from reclaimed walnut, thick as a butcher's block, smooth as glass. He began making small boxes, jewelry boxes, keepsake boxes, the kind people pass down through generations. Dovetail joints cut entirely by hand. Each one took weeks. Each one was perfect. Every morning at 5, while the neighborhood was still dark and silent, Arthur would unlock that garage door, turn on the amber shop light, and pick up his finest chisel. Arthur took lisinopril, 10 milligrams, every morning at 8 with his breakfast. His doctor reviewed his chart at every 1 p.m. appointment and told him his pressure was beautifully controlled, 124/80, consistent, textbook. At 5 a.m., his blood pressure was 182/114. No one measured it, no one asked. The trembling began about 18 months ago. Not constant only in the early morning. Only during that pre-dawn hour when his hands should have been steadiest and his mind most focused. The chisel would slip. A cut would drift a millimeter off the line. A dovetail he had spent 4 days fitting precisely would be ruined in a single unsteady stroke. He stopped going to the studio before 7. Then before 8, his wife began finding him at the kitchen table in the dark, both hands wrapped around a coffee mug, jaw set, waiting for something to pass. She stopped asking what was wrong. She already knew the answer he would give, just tired, and she no longer believed it. Arthur was not declining. Arthur was unprotected. His chart said everything was fine. His morning said otherwise. To understand why your doctor still tells you to take your pill in the morning, you have to go back to the original pill. The first blood pressure medications were aggressive diuretics, powerful water pills that forced your kidneys to flush fluid rapidly and continuously. Prescribing one at bedtime was genuinely dangerous. Patients either didn't make it to the bathroom in time, or they fell in the dark trying. Broken hips, head injuries, emergency room visits. So every physician delivered the same instruction, without exception. Take it in the morning. That guidance was medically sound in 1955. Then, across the 1980s and 1990s, an entirely new generation of blood pressure medications arrived. ACE inhibitors like lisinopril, ARBs like losartan, calcium channel blockers like amlodipine. These drugs work through completely different mechanisms. They do not trigger urgent bathroom trips at 2 in the morning. The original reason for morning dosing had quietly become obsolete, but nobody sent the update. The instruction passed from physician to physician, decade after decade, like a rule, so old, no one remembers why it exists. Arthur's amlodipine carries zero diuretic effect. There is no physiological reason it must be taken at sunrise. But that is what his prescription said. And like every patient before him, he never thought to ask why. Here is what your body actually requires. During deep sleep, your cardiovascular system is designed to shift into recovery mode. Stress hormones recede, blood vessels soften and expand, your heart rate slows. Blood pressure is supposed to fall 10 to 20% below its daytime level, a restorative valley physicians call the nocturnal dip. Your heart needs that valley. Your kidneys depend on it to process overnight fluid. Your brain's smallest vessels require that sustained low-pressure window to repair the microscopic wear that accumulates daily. In younger, healthier adults, this dip occurs automatically. In people over 65, it frequently does not. Decades of chronic inflammation and arterial stiffening have dulled the nervous system's ability to apply the brake. Pressure remains elevated through the night, not dramatically, but relentlessly, and the damage accumulates in silence. Nearly half of all adults over 65 have lost this nocturnal dip entirely. They are classified as non-dippers. Most have no idea, because their physician measures blood pressure at 1 in the afternoon, when the medication is fully active and the number looks reassuringly normal. Non-dippers carry 2.5 times the risk of silent cerebrovascular damage, the kind that surfaces not as a dramatic event, but as a slow dimming. Misplaced words, forgotten names, a growing fog that everyone around them quietly attributes to age. It is not age. It is pressure that never rests. Arthur's wife had started finishing his sentences. She told herself it was nothing. She was wrong, but the cause was not what she feared. His brain was being worn down nightly by pressure. His medication was no longer present to control. Your body will often tell you this is happening, if you know what to listen for. Waking 2 or more times each night to urinate may not be a bladder issue. It may be your kidneys working against sustained, elevated pressure, attempting to reduce fluid volume as a compensatory measure. Every pre-dawn bathroom trip may be your body's quiet distress signal. Ankles that appear swollen at sunrise but normalize by afternoon indicate fluid accumulating overnight, a direct consequence of pressure that never dropped low enough for proper clearance. And a dull, heavy ache at the base of your skull that greets you each morning and fades by mid-morning is perhaps the most telling sign of all. That is not tension. That is the morning surge colliding with vessels that receive no overnight rest, vessels already strained, suddenly asked to absorb a pressure spike with nothing in your bloodstream to cushion the impact. Arthur had all 3 symptoms. He mentioned none of them to his doctor. He assumed they were simply the texture of being in his 70s. They were not aging. They were evidence of a 6-hour gap that opened every single night while his medication waited on the shelf for morning. Then came a study that forced the entire cardiology community to stop and reconsider something it had assumed for 7 decades. Researchers in Spain enrolled over 19,000 patients and followed them for 6 years. The design was straightforward. Half continued taking their blood pressure medication in the morning, as instructed. The other half took the exact same pills, at the exact same doses, but moved them to bedtime. Same medications, same patients, different clock position. The bedtime group experienced 56% fewer fatal cardiac events, 49% fewer strokes, 42% fewer cases of heart failure. Not modest improvements measured in fractions, dramatic reductions in the events that end lives or permanently alter them. When those numbers circulated through the medical community, the reaction was not immediate adoption. It was skepticism. Physicians argued the effect was implausibly large. Critics noted the study originated from a single region of Spain and questioned whether the results would hold across broader, more diverse populations. Science, appropriately, demanded replication. So a second trial was conducted in the United Kingdom. Over 21,000 patients. 5 years of follow-up. Morning dosing compared directly against evening dosing across a wide cross-section of the population. The outcome differed from the Spanish findings. No statistically significant reduction in heart attacks or strokes was detected between the 2 groups. 2 large, rigorous studies. 2 different conclusions. But here is what both studies confirmed, without any ambiguity whatsoever. Evening dosing is completely safe. The UK trial documented no increase in nighttime falls, no dangerous pressure drops, no elevated fracture risk, no adverse outcomes of any kind associated with taking blood pressure medication at bedtime. The concern that made morning dosing standard practice in 1955, the risk of patients being harmed in the night, was definitively put to rest. That leaves you with a clear calculus. At its absolute worst, based on the most conservative reading of the available evidence, switching to evening dosing produces outcomes identical to morning dosing. At its best, it cuts your risk of dying from a cardiovascular event by more than half. Identical safety floor, dramatically higher potential ceiling. And for those who have lost the nocturnal dip, whose blood pressure runs elevated through every sleeping hour, an evening dose does something morning dosing structurally cannot. It places the medication at peak strength precisely when your body needs protection most. Forcing the restorative pressure drop your cardiovascular system has quietly stopped producing on its own. The shift registers on a home blood pressure monitor. Within 48 hours, you take the pill tonight. Tomorrow morning, the number you see will likely be one you have not seen at that hour before. Before you do anything else, understand this clearly. The evening timing strategy does not apply uniformly to every blood pressure medication on the market. Getting this distinction wrong matters in ways that can cause real harm. So let me be precise. 3 categories of medication are specifically positioned to benefit from evening dosing. ACE inhibitors, lisinopril, ramipril, benazepril, ARBs losartan, valsartan, olmesartan, calcium channel blockers amlodipine, diltiazem, felodipine. These drug classes work by interrupting the hormonal and vascular mechanisms that drive blood pressure elevation. Those same mechanisms, the renin-angiotensin system, the stress hormone cascade, reach their biological peak during the overnight hours and detonate fully in the early morning surge. Taking these medications at bedtime is not simply a scheduling preference. It places peak drug concentration in your bloodstream at the precise biological moment your cardiovascular system faces its greatest daily threat. The timing alignment is purposeful and measurable. Now, the medications that must not move to bedtime: diuretics, hydrochlorothiazide, furosemide, chlorthalidone, operate through an entirely different mechanism. They lower blood pressure by prompting your kidneys to eliminate excess fluid, which means they prompt you to urinate repeatedly and urgently. Prescribing one at 9 p.m. means your night becomes a series of trips down a dark hallway, each one requiring you to rise quickly from a horizontal position while your blood pressure is pharmacologically suppressed. That combination, darkness, disorientation, rapid positional change, lowered pressure, is precisely how serious falls happen in people over 65. A hip fracture after 70 carries a mortality risk of 20 to 30% within the following 12 months. That is not a statistic to negotiate with. If you take a diuretic, ask your physician about shifting it to late afternoon, 4 or 5 p.m. The fluid elimination cycle completes before you sleep. The blood pressure benefit extends through the night. You keep the therapeutic effect without the nocturnal hazard. Beta blockers metoprolol, atenolol, carvedilol require separate consideration entirely. These medications reduce heart rate directly. Your heart already undergoes a natural, necessary slowing during deep sleep. Introducing a beta blocker at bedtime risks compounding that effect beyond what your cardiovascular system can comfortably sustain. That specific decision belongs exclusively to your physician. Do not move a beta blocker without an explicit conversation. Know what you are taking. Know which category it belongs to. Then have the right conversation. Walk to your medicine cabinet tonight. Read the labels. If you find lisinopril, ramipril, losartan, valsartan, or amlodipine among your medications, those are the ones worth discussing with your physician. When you sit down at your next appointment, say something close to this: I've been monitoring my blood pressure at home, and my morning readings are consistently higher than what you measure here in the afternoon. I'm wondering whether my medication is losing effectiveness before the early morning surge. Would it be appropriate to try taking it at bedtime, with close monitoring to ensure nothing drops too low overnight? Those words accomplish three things simultaneously. They demonstrate you have been paying attention. They position your physician as the authority making the final call, and they give your doctor a clear, clinically reasonable path to say yes. If the answer is no, do not push back. Instead, say this: I completely understand you know my full history far better than I do. Would a 24-hour ambulatory blood pressure monitor be worth considering, so we can see exactly what my readings look like at 3 in the morning? That request closes the conversation with data rather than debate. What a monitor reveals at 3 a.m. will make the case more effectively than any discussion could. Now, 4 things may be quietly dismantling your nighttime blood pressure regardless of when you take your pill. Aged cheese after 6 p.m. Cheddar, Gouda, Parmesan cheeses that have been cured contain elevated concentrations of tyramine, a compound that triggers your nerve endings to release stored adrenaline directly into your bloodstream. Your vessels constrict, your heart accelerates. The nocturnal dip you need evaporates over a routine evening snack. The pressure increase can reach 5 to 10 points overnight. Replace aged varieties with fresh alternatives: ricotta, mozzarella, cottage cheese, which carry none of the tyramine load. Sleeping flat on your back. A fully horizontal position allows throat tissue to shift backward under gravity, partially narrowing your airway. Your brain detects the oxygen reduction and activates the alarm system adrenaline release. Vessel constriction. Heart rate elevation as many as 25 times per hour without waking you. A wedge pillow or side sleeping position keeps the airway open and the alarm silent. Taking your pill with a full glass of water. 16 ounces, consumed at 9 p.m., becomes an urgent bladder at 2 a.m. You rise, turn on a bright light, and fracture the deep sleep cycle your brain requires for pressure regulation. 2 ounces is sufficient to swallow any pill. Concentrate your fluid intake before 6 p.m. The 10 o'clock news. Your stress hormone levels are physiologically designed to reach their lowest point of the entire day between 10 p.m. and midnight. 30 minutes of televised crisis, conflict, and alarm reverses that descent completely. Your vessels remain tight through the first critical hours of sleep. The dip never arrives. Switch the television off by 8. Open a book. Your cardiovascular system will respond that same night. Arthur had 3 of the 4 saboteurs working against him simultaneously. Aged cheddar and crackers every evening around 8. The 10 o'clock news running until his eyes closed to the sound of someone describing a crisis, and a pill sitting in his medicine cabinet, faithfully swallowed every morning with breakfast, providing zero protection during the hours that mattered most. His son-in-law was a pharmacist. He visited one Sunday afternoon and noticed Arthur at the kitchen table, jaw tight, both hands wrapped around a coffee mug at 9 a.m. The garage door still closed. He asked one question. "What time do you take your lisinopril?" 7 a.m., Arthur said. "Every single morning. Never missed one in 5 years. And the headaches, when do they start?" "Around 5. Before I even get up." His son-in-law set down his cup. "Your medication is essentially gone by 5 a.m. The drug peaked yesterday afternoon. By the time your blood pressure surges in the early morning, there is almost nothing left in your bloodstream to meet it. That headache is the surge hitting unprotected vessels." Arthur sat with that for a long moment. 5 years. Every single morning, sitting in the dark, waiting for the pain to recede, believing it was simply the price of getting older. The answer was not a specialist, not a new diagnosis, not a different prescription. It was moving the same pill from 7 a.m. to 9 p.m. His son-in-law called Arthur's physician that week and walked through the clinical rationale. Lisinopril carries no diuretic effect, no fall risk, no contraindication for evening dosing. The physician agreed to the switch immediately and asked why no one had raised it sooner. He also advised Arthur to eliminate the aged cheese after 6 and turn the television off before 9. Arthur took his lisinopril at 9 p.m. that night. Day 2. He woke at 4:45 and remained completely still on the edge of the bed, waiting for the familiar pressure to build behind his eyes. It did not come. A faint heaviness, nothing more. He stood. The room held steady. He walked to the kitchen, filled the kettle, and noticed his hands were not trembling against the handle. The house was dark and quiet. His wife was still asleep. The garage door was still closed. But something had already shifted. Day 3. He checked his pressure at 5 a.m. with the home monitor his son-in-law had left on the counter. The cuff inflated, deflated, and produced a number he had never seen at that hour in his life. 116 over 74. His afternoon readings at the doctor's office had always landed around 122. His actual mornings had been running at 178 for 5 years. No one had ever looked. No one had ever asked. Day 5. 5:10 in the morning. Arthur unlocked the garage door and stepped inside. The amber shop light buzzed on. The smell of walnuts, sawdust, and linseed oil settled over him like something familiar returning home. He crossed to his workbench, picked up his finest 1/4-inch chisel, and examined a dovetail joint he had abandoned 3 weeks earlier. The fit slightly off, the gap just visible enough to bother him. He repositioned the chisel, set the angle, applied pressure with steady, even hands. The cut was clean. The joint closed perfectly. He stood at that bench for a long time, not because something extraordinary had occurred, because nothing had. No pain, no trembling, no pressure building behind his eyes, no voice in the back of his mind telling him to put the tools down before he ruined something. The garage was his again. Week 2. His wife noticed he was gone before she woke up. She would find sawdust on his boots by 6 a.m., the faint smell of wood oil on his hands at breakfast. One morning she watched him from the kitchen doorway bent over his workbench, completely absorbed, moving with the quiet confidence of a man fully inhabiting his own life. She said nothing. She went back to making coffee, but she was smiling. Week 3. Arthur began noticing things he had quietly stopped expecting. He remembered where he had placed his reading glasses without retracing his steps. He recalled appointments without being reminded. He walked into rooms and knew precisely why he had come. His wife had been finishing his sentences for over a year. She stopped. She did not announce it or make anything of it. She simply stopped, needing to. One evening over dinner, she looked at him across the table and said, "You seem like yourself again." He said, "I feel like myself again." His brain had been sustaining silent damage every night for 5 years. Small vessels pounded by pressure that never received its nightly reprieve, never dropped into the restorative valley that memory and cognition depend on. The clarity returning was not a placebo. It was biology finally given the conditions it required. At his next appointment, Arthur brought a handwritten log. 2 columns, 14 days, morning and evening readings, side by side. His physician scanned the morning numbers 118, 114, 120, 116, 119, and looked up slowly. "These are remarkable for you," he said. Arthur replied evenly. "You've never seen my morning numbers before. Every appointment I've ever had with you was at 1 in the afternoon." His physician ordered a 24-hour ambulatory monitor. The results confirmed complete nocturnal dipping pressure falling appropriately through every sleeping hour. The morning surge blunted before it could build. His heart was resting. His brain was recovering. Then his physician said something Arthur had not anticipated. "I want to talk about whether you still need the second medication. Not adding anything, reconsidering what you're already on." 4 months later, Arthur completed the most intricate piece he had ever built. A small walnut jewelry box with hand-cut dovetails on all 4 corners, a fitted interior tray, and a lid that closed with the soft, precise resistance of a well-made thing. He entered it in a regional woodworking exhibition. He won first place. When the judge handed him the ribbon and asked about the joinery, Arthur answered without hesitating, without searching for words, without his wife stepping in beside him. She was there, but she was not holding his arm. She was not watching him carefully for signs of strain. She was simply standing next to her husband, listening to him talk about something he loved, the way she had decades ago. Arthur did not just move a pill. He got his mornings back, his hands back, his mind back. The quiet pride of a man who builds things that last, recovered from the same prescription he had been filling for 5 years. Taken at a different hour. Picture tomorrow at 5 a.m. You open your eyes. The room is quiet. No vice grip behind the eyes. No heart hammering against your ribs before your feet touch the floor. You reach for your blood pressure cuff almost out of curiosity, and the number looking back at you is one you have never seen at that hour. You bring 2 weeks of those numbers to your next appointment. Your physician looks at the log, looks at you, and says, "Why didn't we do this years ago?" Your spouse stops watching you from across the room with that particular kind of worry they have never quite put into words. Your children stop having quiet conversations about your health when they think you cannot hear. The morning stops being something you endure and becomes something that belongs to you again. I hear this regularly. A woman who made the switch told me her doctor stared at her morning readings in silence before finally saying those exact words. A man told me his wife noticed he had stopped grinding his teeth at night, something she had lived with for years, and that they both slept through the night completely for the first time in nearly 4 years. That is what happens when your medication works with your body's rhythm instead of against it. Same pill, same dose, same pharmacy, different hour. Within 48 hours, your body begins defending itself. During the window, it was completely exposed. But I want to be direct with you about something important. The timing adjustment is a critical first step. It forces the nocturnal dip. It blunts the morning surge. It buys your cardiovascular system the recovery time it has been denied. It does not, however, address the underlying reasons your body stopped producing that dip on its own: the arterial stiffness, the chronic low-grade inflammation, the exhausted autonomic brake system that should have been regulating your pressure through the night all along. The timing fix opens the door. Rebuilding the system requires the full protocol. I am Dr. Alex Thompson. If this reached you at the right moment, share it with one person tonight. The one who takes their pill with morning coffee, whose afternoon appointments always read fine, who sits somewhere quiet every morning waiting for the pain to pass. They deserve to know what Arthur knows. Leave 2 things in the comments right now: what time you currently take your medication, and whether your mornings feel the way I described. Your answer may be the reason someone else finally asked their doctor the right question. I will see you in the next one.